Welcome everyone to the second EHA CTCL podcast series. My name is Maarten Vermeer. I'm head of the Department of Dermatology at Leiden University Medical Center, and my expertise is the field of cutaneous lymphomas. This is the second podcast in a two-part series discussing CTCL, from how to diagnose through to how to treat and manage complex presentation. In the second podcast, we will be concentrating on the treatment of CTCL and new developments that are emerging. And with me is my co-host that will introduce himself now.
Thank you. My name is Erik Marijt. I'm a hematologist at the Department of Hematology at the Leiden University Medical Center in the Netherlands. And my field of expertise is allogeneic stem cell transplantation for hematological malignancies.
So let's start with an introductory question, which is as follows. How are treatment decisions made?
Yeah, well, first of all, of course, we always want to know what the patient expects from us. And when we've decided treatment goals together, then usually, of course, the first part of the treatment is made by the dermatologist, and the hematologist and radiation oncologist will be involved whenever that's necessary for patient care. So what kind of treatment options would you start with, Maarten?
Well, in this discussion, let's focus our attention a little bit to mycosis fungoides and to a lesser extent also anaplastic large cell lymphomas. But in particular, mycosis fungoides should be viewed as a chronic disease. And this is as opposed to anaplastic large cell lymphoma, where some tumors can be treated effectively with radiotherapy, and then around 50% of patients will have no recurrence of disease. But in mycosis fungoides is typically a chronic disease. So our leading principles or cornerstones in the management here is that we treat what we see. We use skin-directed therapies as long as we can, and only revert to systemic therapies if indeed extracutaneous localizations develop. We can upgrade and downgrade our treatments as needed, and we can re-challenge or retreat using the same treatments. And quality of life should be one of the leading principles, as this is a chronic situation, of course.
Great, thanks. And with what kind of particular skin-directed therapies you would start your treatments?
Yeah, so topical treatments would be the preferred treatment choice for early stage MF. So with patients with patches and plaques, then the topical ointments would be the preferred choice, or in those patients with extensive patches and plaques, light therapy is more attractive. If an individual tumor develops, radiotherapy would be a good choice. Then, if the disease progresses, unfortunately, this is only in a minority of patients, but if in those patients in which indeed there is a large number of tumors developing in skin combined with extracutaneous spread to lymph nodes or even metastasis to visceral organs, then chemotherapy followed by an allogeneic stem cell transplant with curative intent would be an option. But of course, that decision should always be made not only with the patient, but in the whole team, including the dermatologist, the radiation oncologist, and of course the hematologist.
Yeah. And also the pathologist, because in a number of cases it will be possible to treat with targeted therapy directed at the CD30 antigen.
Yeah, agree.
Yeah, and well, I agree. As you mentioned, whenever systemic therapy should be started for a patient, then basically what we always would like to do is give it a follow-up with an allogeneic stem cell transplantation to try to cure this disease, because we know by giving mono or polychemotherapy, we are never able to cure the patient. And in the case of an allogeneic stem cell transplant, there are definitely evidence that the graft versus lymphoma effect can cure the patient from his or her disease.
Thank you. So indeed, there are several options that we have available in those patients that do have systemic disease, including different types of chemotherapy, which can also be combined with an allogeneic hematopoietic stem cell transplantation. So my question to you is, who is appropriate for each of these options? How do we make a choice?
Yeah, so I think the cornerstone of systemic treatment for patients with advanced disease is to effectively treat the tumor and trying to avoid severe side effects. And giving monosystemic therapy or systemic monochemotherapy is preferable to polychemotherapy, because polychemotherapy consists of CHOP or tube-like therapies, and that is associated with severe side effects such as neutropenia, admission into hospitals because of high fevers and septicemia, etc. And with monochemotherapy, these side effects are far less. So usually we choose either liposomal doxorubicin, which has reduced toxicity, also a lesser effect on the cardiac muscles, and it has an overall response rate of about 41 to 88%, and a total time to progression of about 13 months. Alternatively, gemcitabine can be chosen, and this has overall response rates varying from 48 to 68%, and an identical time to progression. If these first-line monochemotherapies fail, then we have to switch, and depending on whether the CD30 antigen is present on the tumor of this patient, we can use brentuximab vedotin. That is a monoclonal antibody directed at the CD30 antigen. And recently, the ALANZA study has been published comparing the treatment of brentuximab versus the treatment of choice by the physician, methotrexate or bexarotene. And this treatment with brentuximab demonstrated 3.7-fold improvement in risk progression and a progression-free survival of about 13.2 months. There's one financial point that, particularly in the Netherlands, we have to be aware of, and that is that reimbursement with brentuximab is only allowed for second-line therapies.
Thank you very much. So this is, as I understand it, the approach that you would take to mycosis fungoides patients with extensive skin involvement and ulcerating tumors, and with maybe also already some involvement of lymph nodes. What would your approach be in a patient with a Sézary syndrome, in which from the beginning we not only have, of course, the erythroderma, but also blood involvement, and in a large number of patients already involvement of lymph nodes as well? As you know, my first line of therapy, when I see those patients, and if the disease is somewhat limited, if you can say so, in a Sézary patient, would be used to use skin-directed therapies. And traditionally, we would use low-dose prednisone, up to, let's say, 15 milligrams or 20 milligrams a day. If that wouldn't be sufficient, we would combine it with interferon, methotrexate, or a retinoid. Of course, a number of patients will not respond satisfactorily to this treatment. Sézary syndrome has a poor prognosis, with 5-year survival around 30%. And at a certain point, we would like to upgrade to a more intensive treatment regime. And at that moment, we would start our discussion together. And I'm very curious to what you would like to introduce as a second-line therapy.
Well, Nowadays, it's possible to give the patients mogamulizumab. The Maverick trial showed beneficial responses regardless of the number of prior therapies. And this is an impressive addition to our tool of therapies for these difficult to treat patients. There was no influence of prior use of HDAC inhibitors. And in some patients who were also treated with an allogeneic stem cell transplantation, there was the consideration that there might be some more severe graft versus host disease, which would be more refractory to graft versus host treatments, to glucocorticoid steroid treatment. Another possibility, for instance, if mogamulizumab fails, would be low-dose alemtuzumab directed against the CD52 antigen. And it has been shown in early studies that an overall response rate of 38 to 86% could be achieved. And one of the major problems in our own experience is that these patients are severely immunocompromised due to the fact that also healthy T cells are eradicated by this kind of therapy.
And I think we've seen some rather difficult to treat infections as well in these patients. Yeah. So what are the side effects of these therapies? Could you say something a little bit about that and how these are being managed?
Yeah. So, for instance, the systemic treatment with interferons can be associated with general malaise, weight loss, and sometimes depression. Even patients might go about killing themselves. So that's also always a warning that I discussed with these patients, that whenever they or their family members notice mood changes, then they have to contact us, and maybe we should refrain then from further interferon therapy. With the chemotherapy regimens that we give, it's always possible to observe myelosuppression, causing febrile neutropenia and severe infections. Sometimes you can observe the hand-foot syndrome. And I must say that in my own experience, the side effects of gemcitabine and the liposomal doxorubicin are relatively limited. Whenever we have to give patients the CHOP or tube therapies, then of course they have much more severe side effects with nausea, anorexia, fevers, severe infections, skin reactions, and in the case of alemtuzumab, also CMV or EBV viral reactivations.
Yeah, so this can be a really complicated picture, because the patients start with skin disease, and then they can also have some of the side effects are presenting in skin. So it sometimes becomes difficult to differentiate the disease from skin reactions, and this is typically also the case in patients with mogamulizumab that develop so-called moga rash in up to 20% of the patients, in particular in the first courses of disease. And then it's always a good idea, I think, to take an additional biopsy, and that can help us very much to see what's really going on. So the next, what I would like to ask you is, when is allogeneic hematopoietic stem cell transplantation appropriate, and why are they a good option?
Well, that's obviously a very good question, because allogeneic stem cell transplantation is a very complicated therapy associated with some very severe side effects, even mortality. And the reason that we would advise designated patients to undergo a stem cell transplant is if they would refrain from this type of therapy, then they certainly would die of their aggressive lymphoma. So basically, when we start systemic therapy, we also try to identify a donor for these patients, and we start looking for an allogeneic stem cell donor in all patients under the age of 75 years.
So why do you choose an allo SCT?
And I assume you mean in contrast to an autologous stem cell transplantation.
Correct.
Well, that's because autologous stem cell transplantation is basically very high dose chemotherapy with stem cell rescue. And we know from literature that chemotherapy can be effective to lower the tumor burden, but always within 3 to 6 months, the patient presents again with progression of his disease. So autologous stem cell transplantation will not differ that clinical pattern. And the allogeneic stem cell transplantation is a form of alloimmune therapy, whereby donor alloimmune T cells can recognize foreign antigens on the malignant cells and can induce a graft versus lymphoma effect. And one of the side effects is graft versus host disease of this form of treatment. And we want to prevent graft versus host disease, particularly in the first couple of months after transplantation. Therefore, we treat the patient with immunosuppressive drugs, and then we start to taper those drugs after 3 to 4 months. And when no graft versus host disease occurs, we will start treating the patient with this alloimmune therapy called donor lymphocyte infusion. And this can be repeated every 2 to 3 months, depending on whether or not an alloimmune response and a graft versus lymphoma effect is observed.
Thank you. Now, I can imagine this type of intensive treatments will also have its drawbacks. So I'm curious what these drawbacks might be and how they can be managed.
Yeah, so as I said, graft versus host disease is a potential complication of this treatment. And graft versus host disease can occur predominantly in 3 organs, the liver, the gastrointestinal tract, and in the skin. Although in the case of patients with cutaneous T cell lymphomas, graft versus host disease, the skin might be considered as the actual therapy instead of a side effect. Other side effects are opportunistic infections. That is because of the immunosuppressive treatment that we give the patients, either to prevent graft versus host and to prevent rejection of the hematopoietic stem cells from the donor. Of course, the most impressive side effect is non-relapse mortality, which occurs in about 20% of the patients. So we have still a major goal to achieve in reducing this relatively high percentage of mortality in these patients. And what I always find basically the most difficult decision is when to perform this allogeneic stem cell transplant. And we would like to do it in a situation of the least amount of tumor cells present in the body of the patient, because that is associated with an increased chance of survival and cure. But of course, because of the high mortality rate, you want to postpone the transplant as much as possible. And on the other hand, you would not want to miss the window of opportunity. And the disease has become too aggressive to manage anymore.
I agree completely. I have the same difficulty, so to say, from the other side of the spectrum. When I'm treating those patients, what is the correct moment to refer the patients to for a stem cell transplantation? This is precisely the reason why we have these combined clinics, and together we try to understand the disease of the patient as good as we can, and to make an assessment as good as we can on how the disease will develop, and then together with the patient make the most informed decision as we can on when to start this therapy. So could you say a little bit about the different allo SCT donor types?
Yes, we always start looking for siblings, which might be HLA identical to the patient. And that are the type of donors that we prefer. If there is no HLA identical sibling available, we start looking for a 10 out of 10 matched unrelated donor. And whenever we find either this 100% matched unrelated donor or an HLA identical sibling, then we can make use of our conditioning regimen which we have recently started to use for these kind of patients, and was first developed by Stanford University and consists of total skin irradiation for about 3 to 4 weeks. Then the patient is admitted to the hospital and is treated 5 days with anti-thymocyte globulin and receives 10 doses of total lymphoid irradiation, and then an unmanipulated stem cell graft. And to prevent graft versus host disease, we start with double immunosuppressive therapy. When we can only find a 9 out of 10 donor, then we will not make use of this new conditioning regimen, but we'll use our own standard non-myeloablative regimen, combining fludarabine, cyclophosphamide, and low-dose TBI. And to prevent graft versus host disease, the patient receives 2 days of high-dose cyclophosphamide post-transplant.
Thank you. So it's, I think, very clear that this is a very complicated and very intensive treatment regimen. Do you see new treatments developing for CTCL in the near future?
Yes, definitely. There are a number of phase 1 and phase 2 trials going on. There are trials with the checkpoint inhibitors directed against the PD-1 ligand with atezolizumab. Another trial studies the effect of an anti-CD47 monoclonal antibody. And there are some clinical trials studying the effect of bispecific antibodies in which activity against the CD30 antigen on malignant T cells is combined with an anti-CD16 activity, an antigen present on natural killer cells. And the idea is to bring these natural killer cells into close proximity of the malignant T cell and then kill the T cells, the malignant T cells. Then there are some small molecules that are studied. PI3 kinase inhibitors, duvelisib, HDAC inhibitors such as romidepsin, and proteasome inhibitors used for the treatment of multiple myeloma such as bortezomib. And finally, almost the holy grail is right now cellular therapy with CAR T cells, in which autologous T cells are transduced with a chimeric antigen receptor against TD30.
Thank you very much. This brings us more or less at the end of this second podcast on CTCL. And in trying to summarize our discussions, I think I should at least mention the following. So, whereas early stage CTCL disease can be managed effectively with skin-directed therapies, as soon as more advanced disease, and in particular if extracutaneous disease localizations develop, we should always discuss in our team with the hematologist what kind of additional therapies are needed. We have covered different type of monochemotherapy, including liposomal doxorubicin and gemcitabine, but also novel developments such as the anti-CD30 antibody brentuximab vedotin, and other antibodies that are being used are mogamulizumab and alemtuzumab. In a selected number of patients, we can decide to perform a allogeneic stem cell transplantation, and of course there are also some novel developments, including the checkpoint inhibitors and maybe in the future also cellular therapy using CAR T cells. This brings us to the end of this second podcast series. I'd like to remind you that this is indeed the second in a series of 2. The first one is available on the EHA campus as well. And with that, I'd like to thank the listeners for their attention and my co-host as well.
Maarten, it was a great pleasure to discuss the treatment and diagnosis of these very difficult patient populations with cutaneous T cell lymphomas. Thanks.
Yeah, thank you. And it's a great pleasure to discuss them with you. And it's also always a great pleasure to discuss patients with you as well.